going to demonstrate a head-to-toe assessment to you today. And before we get started, the things that you need to have at the bedside before you come into, before you do your assessment: gloves, a tongue blade, alcohol, a pen light with working batteries, and your stethoscope. With the return competency, you'll have to have your sheet signed with the 3 signatures. What I'm going to do today is demonstrate the whole head to toe. When you come in for competency, you're only going to have to do 1 or 2 of the segment assessments, not the whole thing. But on your patients, you'll have to do a whole head to toe assessment every day on every patient that you take care of. So when you walk in, one of the first things you're going to do is hand hygiene. Introduce yourself. Mrs. Morgan, I am Tamara, and I'm going to be doing your assessment today. And have you ever had an assessment done? They're going to answer yes or no. But I'm going to tell her that it's a process of looking and listening to her from her head down to her toe. I'm going to ask her, I've already called her Miss Morgan, so I've already introduced that. But so now to check her orientation to self, I can ask her what her first name is. Ask her the date of the month and the day of the week. Ask her the current president. Things that would identify to you whether or not she was oriented ×3, and that's person, place, and time. Then when the rest of the thing I'm going to do is come in and get ready to do her head assessment. Ask her if she's fallen. If she has not had any recent falls, there's no reason for me to assess her head. I'm going to look at her pupils. To do that, I need to get the size of her pupils before I shine the light in her eyes, and pupil size are measured in millimeters, and that's the size that you want to get before you shine the pen light. So her pupils, 3 millimeters. I would turn off my light and then shine with the pen light, have her look at my nose. I'm going to adjust the head. Can you look at my nose? And I'm going to go from out to in, and then out again. When I do it the second time, I'm looking for consensual movement of the opposite eye. Come in, out, sweep under the chin, and now I'm looking at my opposite eye. Go in, out, again for consensual movement. And consensual movement is that both of the pupils should, when the light is shined in, should constrict. And then when you remove the light, they should dilate. If she's not had any recent problems with her nose, there's no reason for me to look in her nose. But while I have my pen light, a lot of times with the tongue blade, people have trouble, the patients have trouble sometimes opening and compressing their tongue down so you can look inside their mouth. So this is just to aid in that, and you really want to look at all of the mucous membranes really good, and then have them say off. Now I'm going to check my pulses at the head, my temporal pulse, right here at the level of the ear. You're going to come across and palpate, and then turn the head, do the same. And all you're doing is checking to see if they're equal and present. You never count the peripheral pulses. The only pulse you're going to count is the apical pulse when we get there. So now for the carotid, I'm going to go midline to the thyroid, over to the side, and palpate. You never palpate the carotids at the same time. And again, midline, over to the side. Now, you can go, there's 2 methods from this. Once you leave the head, then you can come all the way down and go all the way down the body, or you can go to the upper extremities, then come back in. I use the method of doing my head and then coming to my extremities. So I'm going to uncover the extremities, and I'm looking to make sure that the skin is warm and tight. Pulses, brachial, in the bend of the arm, radial, thumb side, and again, radial on the opposite. Again, I'm just making sure that they're present. Have her or squeeze your hands on command, squeeze and release. That is an example of them being able to follow commands. check for capillary refill by blanching the nail and then releasing it. Should be within less than 3 seconds. Now we're ready to come back into the body and listen to heart and lung sounds. So I'm going to bring down the chest of her gown to expose her chest a little bit. I'm going to get my stethoscope, and at this point, I'm going to clean my diaphragm. Not necessarily my earpieces if they've only been in mine. Diaphragm and my bell. This is part of the infection control. Now, I also tell my patient that I'm going to be listening, and there will not be any conversation during this time. And I will tell her when I'm going to switch and go to lungs, because I will have to give her some instructions to take some breaths in and out. But first, we're going to listen to heart sounds. I'm going to use my sternal as my guide. Here, we're first going to listen to, I'm going to point to them, then we're going to listen. We're going to listen first. Second intercostal space, right of the sternum, is the aortic valve. Then I'm going to come over, same, to the left of the sternal, second intercostal space, and listen to the pulmotic. Then I'm going to come down to the fourth intercostal space, to the tricuspid. And I'm real close to the sternum. Then I'm going to move out a little bit using the mid-clavicular to nipple line. Fifth intercostal space is the mitral valve. For the point of maximum impulse, which they call the apical pulse, it is the apex of the heart, and it's still at the fifth intercostal space, but diagonal to the nipple line here. But in dealing with your patients, not always can you hear the apical pulse at the point of maximum impulse. So any of the anatomical places that we have pointed to, you can get an apical pulse, which is listening to the heartbeat for 1 full minute. Now you're going to see me use my stethoscope. Aortic, pulmonic, tricuspid, mitral, point of maximum impulse. Now we're going to listen to lung sounds. Now this is where I'm going to ask my patient to take some good deep breaths in and out, and I have to listen to the lung sounds with one continuous respiratory cycle. And I'm going to start right below the clavicle. And you have breath sounds above the clavicle. The lung tissues actually come up in this area, but we're going to start right below the clavicle. And the sequence is that you're going to listen, and it doesn't matter which side of the body you begin with, but you're going to listen, compare, drop down, compare, drop down, and compare. We're moving away from the sternum, whereas in the heart we were close to the sternum. Now we're listening to lung sounds we're away from. So you're going to see me now with the stethoscope. The space that I'm moving is a diaphragm and a half when I'm moving my stethoscope down. Now, with someone that has large breast, you may ask the patient to lift their breast up so you can listen under, or you may ask them if you can lift the breast up. So that's just something that you'll have to work with. Now, the next breast sounds is at the mid-axillary. We nipple line, mid-axillary. And it's easier to listen to these breath sounds while you're listening to the anterior. Okay, that finishes the anterior chest. Now we're going to move to the posterior chest. Again, you have your patient sit up. Okay. So here, with the posterior lung sounds, we're going to have some landmarks again. We have our spine and our scapulas. We don't want to listen over bony prominences. So again, we'll be placing the stethoscope in a listen and compare, just as we did in the anterior. Doesn't matter which side that you start, you just want to listen, compare, drop down, compare. Again, we're dropping the stethoscope a diaphragm and a half. At this point, I'm past the scapula, so now I can start moving further down in the lung fields and compare. I'm dropping down. Now I've got this space right here that I'm going to have to step it off. When you're listening to lung sounds, you're listening to whether or not the lungs are clear, wheezes, or crackles. Now, we are through with the anterior and posterior lung sounds and heart sounds. So the next thing we want to do is the abdomen. You have to raise their gown up. Now with the abdomen, you're going to look, listen, and feel. So very first thing, we're going to look and make sure the symmetrical of the abdomen. Then we're going to listen, and when we listen, we're going to divide the abdomen into 4 quadrants. Right lower, right upper, left lower. And I'm listening until I hear bowel sounds. Now I'm going to gently palpate. Does that hurt anywhere? Is what you would ask. You would watch for any facial grimacing. Now at this point you would ask when their last bowel movement was. If it's been more than 3 days, that needs some intervention. The only assessment you do with the perineal area as far as urinary is to ask them if they have any pain with urination, any burning, any frequency, and then that would entail some more assessment. During palpation, you want to also palpate the bladder area to make sure that it is not distended above the pubis bone. Okay, moving down to the lower extremities. And when you go to the lower extremities, I like to come to the foot of the bed. And I'm looking at the skin tone of their lower extremities, checking for the warmth, any edema, having them push against my hands to see if they, what kind of lower extremity strength they have. You can bring your hands to the top of their feet, have them bring their hands, their toes toward them. That also gives you some idea of their strength. You can also ask them if they can raise their leg or bend at the knee, and that again gives you some idea of some mobility. Now, this is for a bedridden patient. Now, if they're up walking around, this is probably not applicable, except for checking their pulses and their capillary refill. So the pulses, once I have looked at their overall skin condition, I'm going to check the popliteal. So we are checking the posterior tibia, which is the inside of the, across from the ankle, on both. Now we're going to come to the pedal pulse, which is between the big toe and this next toe up on the bony arch. And if you come all the way up, you can feel that. You have to be against that bony arch. Again, you're just feeling to see if it's present and equal in strength. In a normal assessment, I do not check the popliteal or the posterior tibias. It is important that you know how to find those pulses when you take care of a medical surgical patient. because of some diagnostic studies they may have had. But routinely, if they've not had any of those diagnostics that would require that, the only pulse that we would want you to always check is the pedal pulse. Check capillary refill, and that again is by pressing on the nail bed, waiting for it to blanch, and then come back. So blanching of the nail beds, again, as I said with the upper extremities, is less than 3 seconds. Your pulses, you chart them as 0 being no pulse, 1+ being weak, 2+ being strong, and 3+ being bounding. So this entails the head-to-toe assessment. The only other thing that we require that you do is always look at their buttocks area, and this can be done if they're bedridden. You need to roll them over. If they get up and go to the bathroom, you need to make sure there's no redness on the coccyx area, where it is a big pressure area for our bedridden patients, or even patients that are not used to being in bed. So this concludes the head-to-toe assessment.